HCC is equal to 2 centimeter without vascular invasion or extrahepatic spread in a patient with preserved liver function and no cancer-related symptoms. Moving to the next stage, which is early stage A, which is again a solitary HCC, irrespective of size, or multifocal up to 3 lesions, none of them more than 3 centimeter, but without any macrovascular invasion or extrahepatic spread, and no cancer-related symptoms. Intermediate stage, multifocal HCC with preserved liver function, but no cancer-related symptoms, no vascular invasion or extrahepatic spread. And then advanced and terminal stage with multifocal disease and evidence of vascular invasion with advanced stage. And whereas with the terminal stage, there is advanced background liver parenchymal disease. This is just an overview of the treatment algorithm that is available for patients, depending upon the stage. For very early and early stage, surgical resection is an option based on the maintained underlying liver parenchymal function. And also there are local regional therapies that are available to patients, varying from radiofrequency ablation, microwave ablation, laser ablation, HIFU, cryoablation, with recent introduction of irreversible electroporation. And as well as recently, there is also histotripsy that is being done for liver tumors, along with external beam radiation and as well as the proton beam therapy. And then for patients with intermediate and advanced stage, given the multifocal tumors, typically these are managed with either transarterial chemoembolization or radioembolization, which is also called TARE, as a bridge to liver transplantation. And for advanced stage disease or end stage disease, there are various systemic immunotherapy agents that are available for use in the current market. So for the context for this lecture is the liver transplant has been shown to lead high rates of recurrence-free survival, particularly in early stage unresectable hepatocellular carcinoma. In the United States, the allocation of transplant is by the Organ Procurement and Transplantation Network. It's called as OPTN, and it's administered by the United Network for Organ Sharing. There's long-standing organ shortage of livers, and hence the goal of the OPTN is for fair and equitable distribution, depending upon the medical agency. So the patients are triaged using the model for end-stage liver disease score. This is based on the biochemical markers of liver dysfunction and predictive of 90-day mortality. However, this MELD scoring system is not ideal for HCC patients, as mortality is more often related to progression of HCC rather than underlying liver function. And hence, these patients are given exception points if they meet the Milan criteria. So early limited disease, either 1 HCC 5 centimeter or less, or up to 3 observations 3 centimeter or less in diameter without distant metastasis or nodal spread, given MELD exception points. And these patients are restaged every 3 months with additional exception points are given as long as patient remains within this Milan criteria before the transplantation. So once the hepatocellular carcinoma is diagnosed and met the Milan criteria, the patients would automatically get a MELD score of 22 out of highest score of 40, and then continue to get 10% increase in every 3 months, as long as the disease remains within the Milan criteria. But the problem with this criteria was that the diagnostic criteria for HCC in the past were vague, meaning some of the descriptions from the OPTN and earlier UNOS was a vascular blush corresponding to the area of suspicion. And leading, because of that broad categorization, the results from the explant liver radiological pathological correlation was very low. And then there was concern that this policy is leading to inappropriate organ allocation with given preference to HCC patients. And hence, there was need for standardization of the imaging to maintain consistency between various readers and across institutions. And and with this standardization, the CT and MRI play a critical role for diagnosis of HCC. Um, and in fact, this is the only malignancy that is diagnosed without biopsy, and they're treated without biopsy and histological confirmation. And hence, standardization becomes even more crucial. And also, the standardization method can help guide management of HCC, whether it is surgery, ablation, or various methods of treatments that are available. And hence, the LIRAD system was introduced. It's developed by the radiologist in collaboration with hepatologists, surgeons, pathologists, taking into input from the American Association of Society of Liver Disease and as well as the OPTN. So what is LIRADS? LIRADS, it standardizes the terminology, interpretation, reporting for CT and MR examinations of liver patients, liver in patients with risk of HCC. It provides a diagnostic algorithm. It provides a lexicon. There is material on imaging technique standards that one needs to follow. And observations are categorized to reflect relative probability of hepatocellular carcinoma. And it's a comprehensive system that also covers vascular invasion, non-HCC malignancies, and as well as some pseudo lesions. So this is the classification of LIRADS from LR1 to LR5, with 1 being benign. And as with the score increase, there is increasing chance of the observation being malignant is higher. This is just an algorithm just to show, I'm going to show examples to how to use this system, but this is just the overview of the algorithm that is used. The key is that this LIRAD system should be used in high-risk patient, meaning either patients with cirrhosis or chronic hepatitis B viral infection. And it cannot be used to categorize lesions that are seen in non-cirrhotic background or in patients with non-chronic hepatitis B virus. So that is very important to keep in mind. So let's look at some examples here. This is MR pre-arterial portal and delayed phase images here. We can see arterial enhancing observation that is showing washout on portal and delayed phase. It is also has enhancing capsule. The diameter of this lesion is 18 millimeters. So using these now fitting into the table, so there is arterial phase hyperenhancement. We look at the diameter. This is 18 millimeters between 10 to 19 millimeters, and it is showing both washout and capsule, so more than 2 features. So that would fall into LR5 category. So this is a classic LR5 example. Moving to the next one. So again, pre-MRI images, pre-arterial and dynamic images. Arterial enhancing observation with washout and as well as capsule. It's 9 millimeters in diameter. So again, if you use the LIRADS categorization, there is arterial phase hyperenhancement. The diameter is less than 10 millimeters. But in patients with lesions less than 10 millimeters, irrespective of how many major features that we have, the lesion cannot be characterized as LR5, and hence this is LR4, probably HCC. This is to maintain specificity of the LIRAD system. So if less than 10 millimeter cannot be LR5 irrespective of the imaging findings. Now, to look at example of LR3, this is pre-contrast. There's a pre-contrast kind of hyperintense nodule or observation. There's no enhancement on the arterial phase. We can see the subtraction image here showing that there is no enhancement on the arterial phase, and some washout appearance related to adjacent liver parenchyma enhancing more than this observation. So this is 17 millimeters in caliber, no arterial enhancement, maybe washout, but no capsule. So arterial phase hypo or iso enhancement, diameter is less than 20 millimeters. There is only one feature washout. So this would be considered LR3 or intermediate probability for HCC. And we would follow this lesion to document any changes over a period of time. Just another example on CT. This is a pre-contrast arterial portal and delayed phase. We can see arterial enhancing lesion. that shows some washout on portal and definitely washout on delayed phase with some pseudocapsule consistent with the LR5 observation. Now moving to the another category of LIRAD system is portal vein thrombus. So on pre-contrast, we can see filling defect within the portal vein. In fact, there is expansion of the portal vein that is showing enhancement on arterial phase, washout on portal and delayed phase images. There is heterogeneity of the liver parenchyma that is better seen on T2 and diffusion weighted images. There is geographical diffusion abnormalities. There is also diffusion restriction within the tumor thrombus that is low on ADC as well. So when we see this, we do not have to go down the pathway. This is consistent with a tumor in vein or LR5 tumor in vein or macrovascular invasion. And OPTN also has a categorization, but OPTN it doesn't address macrovascular invasion. Only LIRAD system has addresses the macrovascular invasion. This is another example of a portal vein tumor thrombus on arterial phase. We can see heterogeneous enhancement of the thrombus. There's some washout on the portal venous phase. Again, this will be consistent with LR5 TIV. Now, moving on to some. Let me move this away 1 second here, sorry. So moving on to some additional ancillary features. So there, in addition to the major features, there are many additional or ancillary features that can be used to upgrade a lesion up to LR4 or downgrade a lesion from LR5 down to up to LR1, depending upon the stability. So these ancillary features that favor HCC are hepatobiliary phase hypointensity. I mean, before I go into, actually, I don't know whether in India we do the gadoxetic acid MRI or Evovist or Primavist MRI, Dr. Ishwar. Do we do?
We don't have that as of now. It's not. It's not available as of now.
Okay. So basically, the gadoxetic acid, which is known as Evovist in US and Primavist in UK and Singapore, is a hepatocellular specific contrast agent. So this gadoxetic acid is taken up by the OATP1B3 receptors that are available on the hepatocytes, and the contrast is accumulated in the liver parenchyma. I'm going to show some example. So with this gadoxetic acid, in addition to doing the dynamic post-contrast, we do hepatobiliary phase that is typically acquired 20 minutes after administration of contrast. And on this hepatobiliary phase, since there is contrast uptake by the liver parenchyma, the liver appears very bright, as in this case. And also there is biliary excretion of this gadoxetic acid, so we can see the biliary duct. And this is what it refers to when we say hepatobiliary phase hypointensity or isointensity. See, most of the lesions that do not contain hepatocytes are going to be hypointense on this delayed phase, like metastatic lesions, hepatic adenoma, cholangiocarcinoma, hemangioma, cysts that matter, all of those going to be hepatobiliary phase hypointense. Majority of hepatocellular carcinomas are also going to be hepatobiliary phase hypointense, but a certain subset of hepatocellular carcinomas can express OATP-B13 receptors and hence can have ISO or hyperintense uptake. And that is what when we are referring to these additional features, some of the additional features. So it's hepatobiliary phase hypointensity. And then, of course, there are additional features such as, restricted diffusion, T2 signal intensity, whether there is intralesional fat sparing, iron sparing, whether there is fat within the lesion. These are all the features that can be used to either upgrade or downgrade. But for example, if the lesion is stable for more than 2 years, that can be downgraded. Or if it has a very marked T2 hyperintensity, or if it follows the blood pool enhancement such that it can be downgraded. So this is the algorithm for using ancillary features using the LIRADS technique. So I'm going to show some examples of some ancillary features here. This is a CT, arterial and portal venous phase. On arterial, we can see kind of heterogeneous enhancement, almost like nodule within nodule appearance. There is some nodular areas demonstrating more enhancement compared to other parts. So this is considered mosaic architecture, although we don't need ancillary features in this case. This is large tumor, but in small subset of cases where major features are equivocal, one could use ancillary features to either upgrade or downgrade an observation. So this is just to show mosaic architecture. This is MR example of HCC, arterial phase enhancement. There's a diffusion restriction, so restricted diffusion can be used as ancillary features. Mild to moderate T2 hyperintensity can be used to either upgrade or downgrade a lesion. And also, if there is intralesional fat or intralesional iron sparing, this is a patient with iron overload. We can see on T2 weighted imaging, the background liver parenchyma is very hypointense, and the lesion is showing sparing of the iron. So iron sparing in iron overloaded liver can be used as an ancillary features. And this is a venous phase showing washout of the lesion. And also, I know this system can be daunting for every day-to-day use, especially if we are not doing frequently. And this is one of the web tools that I developed along with one of my colleagues. It's available free of cost. It's at www.lyrats.net. So there can be a quick app or detailed app. So if you launch the quick app, all you need to do is give the lesion size and just select the arterial enhancement, washout or capsule, and it's automatically going to generate the categorization. Also, one can do detailed app and use the ancillary features for further categorization as well. And also it can generate report if you click it, and then it gives the structured report that can be copied onto any dictation software. Now moving to local regional therapies that are available for these patients. So again, there are wide range of liver-directed therapies that are available, ranging from ablative techniques, radiofrequency, microwave, to transarterial chemoembolization, and as well as radioembolization of these tumors. And LIRADS also has algorithm to assess treatment response after these liver-directed therapies. And there is a recent update in 2024 with this characterization. So basically, it's divided the treatment into two categories. One is non-radiation type, like either ablation or transarterial chemoembolization. And after treatment, these are divided into non-viable, equivocal, or viable. I'm going to show some examples. So if there is after ablation or transarterial chemoembolization, if there is a persistent mass-like enhancement, that would be LRT or viable. But if there is only like minimal peripheral enhancement, it's not certain whether that is completely non-viable versus truly viable, then one would keep it under equivocal and will follow. Whereas with the radiation, whether it's external beam radiation or Y90 therapy, instead of equivocal, we have this LRTR non-progressing. So the idea is sometimes, unlike the ablation and transarterial chemoembolization, this radioembolization or external beam radiation, it takes time for the enhancement to go away. So as long as we see enhancement, but that is stable or decreasing over a period of time, that is okay, and that is called non-progressive. But if there is a arterial or mass-like enhancement that is new or increasing, then that would be considered viable, whereas non-viable would be no mass-like enhancement. So that is the rationale for using two different types of treatment response algorithms. So here is an example. There was an arterial enhancing lesion that has been ablated. So there is no enhancement. There is some hyperdensity on pre-contrast, no arterial enhancement. So this is LRTR non-viable. Another example, this is a pre-microwave ablation. There is arterial enhancing observation, LR5. And that has been microwave ablated. We can see the ablation tract, ablation cavity, but on the post images, there is some degree of peripheral enhancement. That's not really not that much nodularity, and we kept it under LR equivocal and followed up. This is a patient who has been treated with radioembolization there is some degree of arterial enhancement persist, but it's decreasing over a period of time. It's not increasing. We can also see decrease in size of the lesion. So this would be considered LRTR non-progressing. Whereas in this patient treated with Y90, immediately it looks like there is some enhancement, but we need one more follow-up to see whether this enhancement stays or decreases or increases. But unfortunately, in 3 months follow-up, we can see increasing nodularity and enhancement. So this would be now from LRTR non-progressing to become LRTR viable tumor. So in brief, the LIRADS helps by standardizing terminology, by providing consistent reports, clear communication between radiologists and clinical teams, and it improves clinical care and research. And also, since, we are helping our colleagues in IR, surgery, pathology, hepatology, standardized management and recommendation can, help our patients receive a standardized treatment. Now, moving into some further details and further nuances of the LIRAD system, these are two different patients, arterial enhancing lesion with washout, LR5, another patient, arterial enhancing lesion with washout, LR5. These two patients treated with local therapies, one patient without recurrence for 2 years, another patient recurred within 2 years with development of adjacent satellite lesions. So category is same, LR5, pathology is HCC, perhaps imaging features same, but outcomes can be different. Another example here, this is arterial enhancing lesion with washout pseudocapsule LR5. This is another example of arterial enhancing lesion with intertumoral vascularity, washout LR5. Category is same, pathology is same, but imaging features are quite different. When we say in this patient, this is large, there are some areas of necrosis, there are some intratumoral, neovascularity. And again, outcome is different in these two subset of patients. Another example here. So this is a rim enhancing lesion that is on biopsy turned out to be hepatocellular carcinoma. So we would give this as LRM, malignant, but not necessarily specific for HCC. But 70% of LRM lesions can be HCC. On biopsy, this is HCC, and this is LR4 lesion on biopsy. This is HCC. So the pathology is HCC, but they can be of different LIRADS categorization, and hence outcome can be different. Particularly the LRM HCC tend to have poor prognosis and poor overall survival compared to a classic LR5 HCC. So to understand these differences, one needs to delve into pathology, molecular, and prognostic radiologic features of hepatocellular carcinoma. So this is the recent WHO classification of hepatocellular carcinoma, which characterizes, other than the conventional hepatocellular carcinoma, which otherwise not otherwise classified, which constitutes for 70%, but 30% of the times it can be one of these types. So steatohepatic type that contains internal fat. Prognosis is similar to the conventional type. Then clear cell HCC, it can contain internal fat. It has a better prognosis. Then macrotubercular massive type, which has large areas of necrosis. It associated with poor prognosis. Squamous type, again, imaging findings can overlap with cholangiocarcinoma. Most of the times, the squamous type looks like LRM, meaning there is now rim type of arterial enhancement and typically worse prognosis. And these are other types of hepatocellular carcinomas that are rarely seen with variable range of prognostic implications. So advanced imaging can identify prognostic markers, which can help predict disease progression and survival. It's predictive markers from imaging offers insights into how a patient may respond to treatment. There is a lot of work that is being done to correlate imaging findings with molecular and pathological findings. And also in pathology, there is a recent trend of characterizing these lesions into proliferative and non-proliferative hepatocellular carcinoma to assess tumor aggressiveness and to also account for the biological heterogeneity. So in proliferative type of hepatocellular carcinoma, these are the histological subtypes: clear cell, squamous, macrotubercular, and sarcomatoid and pleomorphic types. And these are associated with a particular genetic pathway, more aggressive tumors, whereas non-proliferative HCC is typically seen in steatohepatic and microtubercular. And also there is a beta catenin pathway that is activated in these subset of patients, which carries a good prognosis compared to proliferative type of HCC. Just to show some of these pathological subtypes, here is a biopsy from a macrotubercular massive. It shows a rim type arterial phase enhancement. There is washout, diffusion restriction, T2 hyperintensity. This would be characterized as LRM because this is a rim enhancement. And on biopsy, this turned out to be macrotubercular massive. This is another classic example. There's non-rim arterial phase enhancement, washout, diffusion restriction, T2 hyperintensity. This would be LR5. Biopsy is clear cell HCC. This is steatohepatic, where we can see intralesional fat in phase, out of phase, signal drop on out of phase images, and an arterial phase heterogeneous enhancement. This is steatohepatic type. This is a KREST type, where there is rim type of arterial enhancement with progressive enhancement on the portal venous phase, T2 hyperintensity, diffusion restriction, and hepatobiliary phase hypointensity as well in the fibrolamellar type. And also there are some additional findings that can help in stratification and risk stratification as well, such as in this case, we can see this peritumoral enhancement adjacent to, so there is a tumor here, and adjacent to the tumor, we see this hyper enhancement. This finding is associated with microvascular invasion. Another example of this peritumoral arterial phase hyperintensity or enhancement. And this is the hepatobiliary phase. And we can see the lesion that is hypointense, but also there is this peritumoral hypointensity. These are all the imaging features that are associated with pathological microvascular invasion. So on imaging, we can predict certain high-risk features to further classify or give prognostic information to the clinical teams. Also, there is non-smooth tumor margin. This is again hepatobiliary phase MR, 20-minute delayed phase. We can see the liver is bright. The lesion is hypointense, but the margin is irregular. This is also associated with poor outcome. This is marked hepatobiliary phase hypointensity, diffusion restriction, corresponding low ADC signal. These are all the features that could indicate aggressive tumor, intratumoral neovascularity, large areas of necrosis, and large size, diffusion restriction. These are all the features that can predict whether it is a proliferative type of HCC or non-proliferative type of HCC. So obviously large size, areas of necrosis, peritumoral enhancement, hepatobiliary phase hypointensity are associated with proliferative type of HCC, whereas small size of the tumor, intracellular fat in the tumor, and hepatobiliary phase isointensity are associated with a non-proliferative type of HCC, and hence, imaging, particularly the LIRADS features, can also predict histology to a certain extent. But in addition, these are all the features that are not included in LIRADS, at least at this time, such as tumor margin, low ADC, peritumoral hepatobiliary phase hypointensity, bile duct invasion, or multiple satellite lesion adjacent to the dominant lesion. These are associated with proliferative HCC, but not included in LIRADS, as well as some features that are associated with proliferative or benign or favorable type of HCC, such as hepatobiliary phase hyperintensity, T1 hyperintensity, T1 ISO, are not included in LIRADS at this time. And yet we know, based on multiple studies, that LR4 and LR5 HCC has good overall survival compared to LRM or rim enhancing HCC, as shown in these survival maps. So to predict LR LIRADS categorization, not only can diagnose HCC, but also certain features can indicate molecular or pathological subtypes. For example, LR3 or LR4 type of nodules tend to have beta catenin mutated HCC and more favorable prognosis, whereas LRM, where we see a rim enhancement rather than uh, uniform lesion enhancement, is associated with poor prognosis and commonly seen in either biphenotypic combined HCC cholangio or macrotrabecular massive HCC or other advanced type of SCIRRS morphology. Whereas a traditional LR5 is commonly associated with not otherwise specified HCC. And of course, macrovascular invasion can be assessed with LIRADS as well. That is always associated with poor prognosis compared to others. So for non-proliferative HCC, there are some features that are already included in a LIRADS, such as LIRADS 3, 4, and these features, whereas proliferative HCC, LRM, LRTIV indicate proliferative, and as well as some features that are part of LIRADS that can predict proliferative HCC as well. Now, moving to systemic therapies that are available to these patients, there has been rapid increase in agents that are available to these patients. In 2007, there was only sorafenib that was available as a systemic therapy option for these patients. But there has been several trials since then with approval of multiple agents for systemic therapy, and it's really rapidly expanded. So for right now, these are the primary agents that are available for patients who are not candidates for either local regional therapy or liver transplant. Typically, patients are started with either BEV combination or Darva with TREM combination, followed by, depending upon the response, there are additional second line agents that are available for these patients. That was already covered. So, and also now there is more and more trend in United States about combining systemic therapies with local therapies in advanced or metastatic HCC to improve overall survival. So the one idea is being that there is a local tumor control. For some reason, it elicits some kind of immunological response or modification of the other lesions in the metastatic sites, and hence these therapeutic agents work better after local therapies. And there are several trials that are ongoing looking at these combination therapies with locally directed therapies to the liver parenchyma, along with immunotherapeutic agents. And initial trends indicate that there is improving overall survival in these subset of patients when treated with liver-directed loco-regional therapy, followed by immunotherapy. And these liver-directed therapies, for some reason, thought to give some kind of immunogenic response or elicit some kind of immunogenic response, leading to increased efficacy of systemic immunotherapeutic agents. So now the buzzword in oncology is about the tumor microenvironment, tumor immune environment. That is the trend. And also there are a lot of trials that are going on along with the radium embolization to the liver lesions, Y90, along with systemic immunotherapy as well. So I do not want to go into those details. It's kind of best interest of the time. But again, there is interest in classifying these tumors and pathology into immune response versus non-immune response, assessing the immune environment of the tumor. There are certain things, again, these beta catenin pathway tumors tend to be non-immune class, so they may not respond very well to the immune therapeutic agents. But there are some features on imaging, peritumoral enhancement, hypointensity, these additional findings that can indicate one way or other. And I'm going to show some examples here. So peritumoral enhancement on arterial phase suggests microvascular invasion, and also it is associated with microtrabecular massive type of HCC, and that is a finding suggesting immune cold HCCs, and these may not respond very well to immunotherapy. And also it has shown on investigative studies that peritumoral hypointensity is also predictive of macrotrabecular massive and immune cold environment. And as well as the hepatobiliary phase hyper HCCs, they contain beta catenin modifications, and these do not respond to monotherapeutic agents. And steatohepatic type with fat within the lesion is showing efficacy against PD-L1 inhibitor therapy. And some of the findings, such as satellite lesions adjacent to the dominant lesion, is commonly seen with macrotrabecular massive, but these patients also tend to do good with the PD-L1 therapeutic agent. So there are some confounding results, but I think work is being done to get more and more out from imaging to see which patients can benefit from immunotherapy versus which subset of patients may not benefit from immunotherapy. So to conclude, LIRADS is a standardized system for HCC imaging. It provides great details with the technique, lexicon, reporting guidelines, and management guidelines. And HCC's diagnosis is made by identifying major imaging features, but there are over 20 ancillary features that can be used to improve detection, increase confidence, and adjusting the category. And we know, based on the current studies, that LIRADS categories are associated with different biological phenotypes and outcomes. For example, we know LRM HCC has poor prognosis compared to LR5 HCC, and LRM has also poor overall. And combined HCC cholangiocarcinomas are commonly seen as LRM, and of course are associated with worse outcomes. And some major and ancillary features can provide clinical insight beyond diagnosis, as well as emerging imaging features not currently integrated in LIRADS to predict the pathological subclassification or proliferative versus non-proliferative type of HCC, and help our colleagues in guiding these patients with appropriate therapeutic agents. Thank you so much, and I'll take any questions now.
Thank you, Venkat. That was a very comprehensive presentation covering the imaging, the pathology, the therapies, and prognostication, including the molecular markers. So thank you so much. We have a wide spectrum of audience today. We have surgeons, we have gastroenterologists, we have interventional radiologists, apart from general radiologists. Professor Jagan, sir, to start with, then we'll follow with the gastroenterology team. Dr. Jagan, you've got something to say?
Yeah. Thank you, Surabhi, for a nice talk, as always. Actually, I have two basic questions. Now, one is in the LIRAD classification, when there is, here we are not using hepatobiliary contrast. But when you have both the contrast, gadolinium and hepatobiliary, so which contrast you use, or both contrasts you use, or hepatobiliary, is it included in LIRAD as a part of the LIRAD classification? This is what.
Yeah. Thank you, Dr. Jagan. Yes, it's a good. So actually, we tend to use non-hepatobiliary phase contrast in the initial diagnosis. And most of the time, 80% of our liver work is actually without using the hepatobiliary phase. And hence, none of the major features are with the hepatobiliary phase contrast agents. Only some ancillary features are with the hepatobiliary phase. But now, at least with the hepatobiliary phase, there are additional features such as either marked hypointensity or hypointense rim around the lesion, showing kind of more prognostic value, and hence there may be a more and more need to image with those patients. Although one thing, what happens with these gadolinic acid contrast is that it's a much smaller volume compared to the regular contrast, and hence it's difficult to do time the arterial phase. But it's very important to have a proper arterial phase in these patients, and hence there is skepticism in using these hepatobiliary phase agents as a primary method for to diagnose HCC.
Thank you. Thank you very much.
Oh, thank you, sir. We have our gastro team who do a lot of liver work. Dr. Gopi Srikanth, you have anything to add or your comments on this?
That's a wonderful lecture, sir. Very comprehensive.
Thank you. Thank you.
Just like your experience on endoscopic ultrasound contrast in the,
Yeah.
are you?
Oh, contrast enhanced ultrasound, you mean, Dr. Gopi?
Yeah. Contrast
Yes.
enhanced.
Yeah. Actually, yeah, I did. Yes. So, we do. I mean, I just moved to MD Anderson about 4 years back. So I was at UT across the street. So we did use it for even for screening purposes for high risk patients. So we have done like more than 250 patients with the HCC patients. It's excellent contrast agents. Only thing is that we need to have a target to use contrast enhanced ultrasound, since we assess the target lesion, and it may not be a great tool to assess the entire liver parenchyma for additional lesions. That is the only comprehension. But per lesion, once we see it on grayscale ultrasound, it can better characterize, because you can do multiple boluses. There is no issue of missing the arterial phase timing. And also there is difference with the HCC versus non-HCC in terms of the washout, whereas colorectal mets or cholangiocarcinoma tend to do washout within 1 minute, whereas HCC tend to have a delayed washout. So it is a great agent in that sense. Only thing is to get a overall picture of for additional lesions in the liver that may not be seen on grayscale ultrasound, we cannot target if you don't see it on grayscale ultrasound. But also we used in the setting of ablation. So real-time ablation, when we are doing microwave ablation, when we are doubtful after ablation is done, still within the needle is when the probe is in the patient, we did scan with contrast to assess if there is any areas that are showing persistent enhancement, so that we can adjust the needle and do the additional ablation. So it's excellent. And we did use it for some of the, if the lesion is not well seen during ablation, use contrast enhanced ultrasound to localize the lesion. So it has tremendous applications in my view. Only thing is that about applying for screening, it may not be able to assess entire liver parenchyma. That's the limitation.
Just like recently, we had a case of this HCC, sir. So it is a 50-year-old male with MASH-related cirrhosis with right lobe HCC post-resection. So now during follow-up, after 4 months, he had new lesions, 9 mm each, in left lobe and residual right lobe. They are showing only arterial enhancement. And in venous phases, there is no definite washout.
Yeah.
But his alpha fetoprotein got elevated from baseline.
That is, yes, Dr. Gopi.
So
in the setting
now,
I agree. That is, we frequently encounter. That's the issue. Whereas this 9 millimeters, we see only arterial enhancement without washout. According to LIRADS, they are LR2, or they are not even, they are not LR4 or 5. So they have to be LR3 or 2. But that being said, in a patient who already had a pathological proven HCC, the chance of these lesions or HCCs are very high. It's just that to maintain the specificity of LIRAD system, we did not want to include under 10 millimeter as LR5. But given the alpha fetoprotein rise, irrespective of what imaging shows, I would be worried that these are satellite lesions and HCCs. Although, again, that's to your point, Dr. Gopi, this is very interesting, because we see tumor, same 3 centimeter, 3 centimeter, looks exactly same on imaging, LR5. One patient recurs within 6 months, other patient is fine for 2 to 3 years. So that's where we are trying to get into with the imaging, with these additional findings. So, looking at pathology, what kind of variant, whatnot.
So just my question is, do you target these lesions by any way? Because only in arterial phase we are able to see this. And we know
Yeah.
that high probability of HCC being there. And
Yeah.
alpha-fetoprotein is high. So like, do you target, or you do wait for the lesions to increase in size?
If it's just a 1 or 2 lesions, Dr. Gopi, and if it developed within the same side of the liver or adjacent to the resection margin, our interventional radiology team is very aggressive. So what they do is, like, during the ablation, they do CT, hepatic arteriography. So they put the catheter within the hepatic artery, inject the contrast, see the lesions, and then they do ablate if it's 1 or 2 lesions, even if it's 9 millimeter. And also with the CT hepatic arteriography, the lesions that were not seen with the additional anatomical images, we may be able to see additional lesions, and then either do the directive therapy, or most of the times, if there are multiple satellite lesions within both lobes of the liver, I think patient would go to the immunotherapy and systemic therapy.
Okay, like which ablation you are they may choose in this case if there are subcentimetry?
I mean, the radiofrequency ablation is the common method here. If they are just 1 or 2, but if they're more than 3 or 4 in both lobes, they would not go with the ablation of each
Yeah, but
lesion.
like
Then
visualization in only arterial phase, can they identify these lesions? That's what we are discussing.
how to
Because
identify?
only
That's the reason why they do CT hepatic arteriography during the procedure, so that they can target the lesion. Because what happens is, when we do the CT hepatic arteriography, when you keep the catheter in the hepatic artery and inject the contrast, these lesions light up way more than the conventional or regular contrast, and hence can be targetable. And also, typically, these 9 millimeters, you want to keep the ablation zone to 2 centimeters, so they can go with anatomical as well. If adjacent hepatic vein or previous resection cavity, whatnot, they can be used. But definitely, it is a problematic area, particularly 9 millimeter. If it's not seen on non-contrast, not every setup is there to do a CT hepatic arteriography. Honestly, sometimes we want to see the biology, so wait for 3 months and see whether lesion increases is also being used. Yeah. So, but it is definitely a difficult target.
Thank you so much.
Thank you, Dr. Gopi, for attending and for insightful discussion.
Thank you, Venkat. We also have interventional radiologist, Dr. Nikhil is there. You want to add something, Nikhil? He does a lot of ablations. He does atrium. He does TACE, ultrasound as a CT guidance. Nikhil.
Awesome.
Yeah. Hello, sir.
I need to.
Hope I'm audible because I'm outside.
Okay, no problem. No, we can hear you.
Yeah, it's fine.
So basically, to add on to the points regarding Dr. Gopi's query. So in Tata Memorial Hospital, I learned that they do lipidol injection into the hepatic arteries, and we do a follow-up scan after a week or so, and see whatever the lipidol retention, whichever lesion is there, that is supposed to be a lesion without cover cells, which is nothing other than HCC in a case of cirrhotic liver. And the lipidol that is deposited also acts as a target for future ablation.
Yeah. Oh, yes, Dr. Nikhil. Yeah, that is a method as well. That is, I've seen being used sometimes here, although they're not using as much as it used to be before. I don't know the exact reason, but that is definitely for smaller lesions. That is a great approach as well. Yes.
Yeah. Nice, insightful lecture, sir. Thank you. Thanks a lot.
Thanks, Dr.
I also have other radiologist, Dr. Jayalatha. You want to add something? A lot of experience with oncology at MNJ Cancer Hospital.
Not getting the audio.
We can hear you, Dr. Jayalatha.
Yes. Yeah, there are so many cases which we see, but majority of them, even after intense radiological evaluation, some of them within no time turn out to be a malignant again. See, in spite of the so many features which you have shown, in an own closed setup, we have seen the lesions being repeated, I mean, increasing in size, which we thought they were very benign and then not a repetitive case. This is my experience in this. And another features which you have seen is very insightful, that you have shown proliferative and non-proliferative and these contrast enhanced lesions. But in our setup, majority of them, what we found out, like further, majority of them, they're not, though we do LIRAD classification and give them but biopsy and the histopathological examination and also the tumor markers, especially for the tumor markers, they do end up doing all these. And what I think is, with these procedures, the microinvasion and infiltration is further on, maybe leading to a early recurrence. That's what I think. In our
with the
setup.
art practice,
Yes.
yeah.
Yes.
Yeah, Dr. Jayalalitha, in regards to the question of these lesions growing, thought of being benign, but then growing on subsequent follow-up exams,
Yeah.
that is, I mean, certain subset of HCCs can be very aggressive.
Yes.
Either maybe we are seeing that kind of subset more often in your practice.
Yes.
I suppose that is what is happening, because we have seen some 2 centimeter lesion growing to a 10 centimeter in some patients, unfortunately, within a span of 3 months as well. And in fact, we have seen in a routine surveillance, 6 months before CT, no lesion, and then patient comes with like 5 centimeter HCC. So I think maybe you're looking into that kind of subset of patients. If the imaging is of good quality, I think that is the only
Maybe
reason.
we need to include all the other epitobiliary contrast and other parameters too, maybe to divide further into.
So I think, one thing that I observed is, like, we need to have a good arterial phase imaging. So if there is any issue with the arterial phase timing, whether it's being early or late, then these lesions may not be seen very well. And also the triple phases, I mean, arterial venous and delayed phase.
It's very difficult to leave the lesions alone, in spite of we characterize them. But this is what the clinician's confrontation comes in, like whether to leave the lesion alone in spite of these features, or go ahead and do the ablation or whatever the process we have. That's where we get little stuck up.
Oh, I see. I get it. Yeah, I know. Practice change. Yeah.
Yes. But it's very nice, insightful lecture. Thank you so much.
Thank you.
Thank you, Dr. Jayalalitha. Dr. Rajgopal, any other comments from any of us?
Hi, excellent lecture. I just have some 2-3 questions. In case of LR5 lesions, depending on what are the morphological characteristic, do you decide to do a biopsy in some cases and don't do biopsy in some cases? Because what is our practice is most of the LR5 lesions directly we discuss in the tumor board and take the management decision. Do you have any other?
Yes, Dr. Rajagopal. Actually, that is the approach that we take as well. In a cirrhotic patients or chronic hepatitis B virus, or in that matter, NASH or NASH-related metabolic associated cirrhotic patients, if we see a classic LR5 lesion, we are not doing biopsy at this point of time, directly treat the patients without biopsy. Only if we see atypical, meaning LRM, instead of uniform arterial enhancement, we see a rim type of arterial enhancement, because those lesions in 30% of the time can be either cholangio or combined cholangio HCC. They don't want to miss that cholangio component. And those lesions we do biopsy, but not LR5. But I feel like, once we treat these LR5, and then if the patient recurs with multiple lesions, that's where they may do biopsy to looking at the target agents, immunotherapy, but that's a last resort. But as a initial resort, we are not biopsying LR5 lesions.
Because molecular subtypes you were mentioning have different prognosis. So in that regard, you don't do the biopsy. Okay.
No, not for the initial LR5. When we are doing a liver-directed therapy or before liver transplantation, we are not doing. Only very advanced stage with bilobar, multiple lesions, more than 10, and local therapies are not an option. Liver transplant is not an option. Then, of course, if the patient condition allows and background liver cirrhotic parameters allows, then we do biopsy and subtyping. but that's
Okay.
only for systemic therapy. But local directed therapy, 1 or 2 lesions, diagnosis and treatment is based on LIRADS. Yeah.
Yeah, as far as liver-specific contrast agent, in India, I think it's only the multi-hands which is available, the gadolinium bopta.
Right.
That also works as extracellular contrast agent also. I think it does give a very good the contrast enhancement pattern as well. That's what we are using right now. And the one more question was LRTIV. Do you want to label that as LRTIV, LR5 lesions,
Typically,
or is it just LRTIV only?
Yeah, typically we call it as LR5 TIV, but sometimes typically the tumors that are associated with the tumor thrombus tend to be ill-defined. They may not show that much of arterial enhancement. They look so different, these infiltrative type of HCCs. And hence, if the reader is not comfortable calling LR5, they can just leave it as LRTIV as well. But we tend to call it as, whenever we see a tumor thrombus, we just call it as LR5 TIV.
Because even some of the cholangiocarcinomas also can invade into the portal veins. So that time, will it be inappropriate to call that as LR5 lesions?
Typically, I mean, at least my experience has been that there can be a portal vein thrombus with colorectal mets or cholangio, but the thrombus, it doesn't enhance similar to HCC tumor thrombus that we see. The tumor thrombus of HCC, I mean, cholangio and colorectal mets tend to be hypo compared to HCC. Yeah. So once we see a neovascularity within the thrombus, I think it's it's reasonable. And most of these patients have very high AFP as well. So.
Yeah. One more short question. The ancillary features, it's only MR ancillary features. No, it's not CT ancillary features as such. Anything in the recent LIRADS?
Only mosaic attenuation, mosaic architecture is the one which can be applied to both CT and MR. But majority of these ancillary features are MR. You are right, Dr. Rajgopal. Yes. Yeah.
Okay. Thank you so much.
Yeah, thank you.
Thank you, Rajgopal. As compared to CT versus MR, what is your current practice like? Which one would you prefer? And they go for CT or they go for MR, or how does it go with you, with your practice and experience?
So actually, a great question, Dr. Ishwar. So in my previous practice, it was a heavy MR dependent. We used to do a lot of MR just because we can see so many other sequences and give diffusion, T2 weighted, whatnot. But MD Anderson is more heavy CT dependent practice. I mean, their protocols, CT protocols are very good. One, since most of the patients are cancer, so I mean, there's not that much effort of decreasing the dose. It's more of getting a good quality CT image. So, and hence CT does fairly well compared to MR. But my preference would be MR for liver because we can see so many additional things. But it's, I think, I practice to practice. But MD Anderson is heavy CT driven for liver work as well. Yeah.
Okay. So one question in the chat box from Gopi. Surabhi.
Yeah. Okay. Let me take a look at it.
Yeah.
So do you agree that non-cirrhotic mass to be added to chronic hepatitis B used to apply LIRADS? Chronic NASH cirrhotic. I don't know, Dr. Gopi. That's a great question. I will take it to LIRADS committee. I'm part of it. Only thing is that before these patients develop cirrhosis, are they at increased risk of developing HCC? I do not know the answer to that question, but I need to look into it really. Yeah.
Yeah, but we from gastroenterology and hepatology point of view, we feel that non-cirrhotic MASH is definitely a risk factor, and we have seen cases also.
Yes. Yeah. I've seen cases anecdotally.
Yeah.
You're right. I think that is a great point. Yeah. Great point. Yes. Yeah. We'll definitely look into it at the LIRADS level.
Any other comments from the audience? Professor Madhusudan Rao, are you there?
Hello, Dr. Surabhi. This is Kavita.
Yeah,
Hi,
Kavita, welcome.
Yeah. How do you stage them? Do you
Staging
use
is HCC staging is based on the BCLC criteria. It's not only the tumor, but looking at the underlying liver function test, cirrhotic status, and then staged.
I think what
at any
Kavita is
stage? Do you use PET CT at any stage for at least poorly differentiated HCCs?
I think the PET we are not using. Only setting that we are using PET is that once we do local therapy to the liver, and then on the CT and MR, if the lesion is showing no viable tumor, but the AFP is rising, and we do not see a lesion to explain increase in AFP, that is the only setting where we do nuclear medicine bone scan first, because most of the times we, HCC tend to go to bones, and if the nuclear medicine bone scan is negative, then only we are doing PET, but very sub-selective, where rising AFP cannot be explained by anatomical imaging.
Thank you. That's nice.
Thank you. Oh, thank you, Surabhi. I think that's a wonderful lecture covering everything. You've done a fantastic job in educating us. Great to see you on the LIRADS committee. Hope when is the next revision or this thing coming up?
So actually, every 3-4 years. So 2024 was the treatment response algorithm changes, but the other application is still due, but they're mostly working on the prognostic factors to incorporate some of these indicators to indicate more aggressive biology. But we'll expect in another 3 years. Maybe sooner to include MASH, maybe, as Dr. Gopi suggested.
Yeah. Fantastic survey. So nice to see you. So nice to see your contribution and your growth at India and the US as well. Hope to see you in another fantastic lecture sometime soon. Thank you so much from KREST, Hyderabad. Good day to you.
Thank you so much,
Thank you.
Dr. Ishwar.
Thank you.
Yeah, thank you. Bye.